Welcome to this essential guide on understanding and managing venous thromboembolism in pregnancy and the Puerperium. Today we will explore the definition, etiology and pathophysiology, risk factors, clinical features, differential diagnosis, investigations, and management of venous thromboembolism in pregnancy and the Puerperium. Pregnant people are at increased risk of venous thromboembolism, VTE, and venous thromboembolism is an important direct cause of maternal death. When discussing VTE, this article will consider deep vein thrombosis, DVT, and pulmonary embolism, PE. Compared to people of the same age who are not pregnant, the risk of VTE increases between 4 and 6 times during pregnancy. However, the absolute incidence remains low, at about 1 in 1,000 cases. During pregnancy, the blood becomes more coagulable. This is due to increased coagulation factors 8, IN and X, increased fibrinogen, decreased fibrinolytic activity, reduced antithrombin levels, reduced protein S levels, increased venous stasis, vascular damage. These changes can be considered protective against excessive blood loss at delivery. Accordingly, the risk of venous thromboembolism increases throughout pregnancy, peaks at the baby's delivery, and slowly decreases back to baseline by 6 weeks postpartum. The absolute risk of VTE is low during early pregnancy. However, this is when most fatal VTE events occur. As such, some form of early risk assessment is required to determine which women should be offered medications which can reduce the risk of VTE. Antenatal VTE risk factors include high risk, any previous non-provoked VTE, mechanical heart valve; medium risk, immobility, e.g. due to prolonged hospital admission; dehydration, e.g. due to hyperemesis; high-risk thrombophilia, e.g. antiphospholipid syndrome; medical comorbidities, e.g. cancer, IBD, SLE, surgery; low risk, BMI 30 kg, age 35, parity 3, smoking, gross varicose veins, preeclampsia, history of unprovoked VTE in first-degree relative, multiple pregnancy, in vitro fertilization or assisted reproduction. Postnatal VTE risk factors include high risk, any previous VTE, antenatal LMBH, high-risk thrombophilia, e.g. antiphospholipid syndrome. Medium risk, cesarean section during labor, i.e. not an elective case, BMI 40 kg, admission, readmission for 3 or more days after delivery, surgical procedure post-delivery apart from repair of the perineum, medical comorbidities, e.g. cancer, sickle cell anemia, SLE. Low risk, BMI 30, age 35, parity 3, smoking, family history of VTE, gross varicose veins, current systemic infection, immobility, e.g. paraplegia, journey 4 hours, preeclampsia, multiple pregnancy, preterm delivery 37 weeks, stillbirth in this pregnancy, prolonged labor 24 hours, postpartum hemorrhage, 1 NEL, or requiring blood transfusion. Signs and symptoms of DVT-PE in pregnancy are similar to those in non-pregnant patients. Typical symptoms of a DVT include unilateral limb pain, often described as cramping and may worsen over several days, unilateral limb swelling, erythema. Typical symptoms of a PE include dyspnea, tachypnea, pleuritic chest pain, hemoptysis, concurrent symptoms of DVT. Typical clinical signs of DVT on examination may include unilateral limb edema, often pitting oedema, erythema, painful limb is warm to touch, peripheral venous distension, tenderness along the line of deep veins, painful movement of the muscles distal to the thrombus. Typical clinical signs of a PE on examination may include tachycardia, tachypnea, hypoxia, low-grade fever, pleural rub, gallop rhythm, a wide split-second heart sound, and tricuspid regurgitant murmur. If a patient develops a massive PE, they may present with hemodynamic instability, collapse, and an elevated jugular venous pressure, JVP. This is a medical emergency. VTE can be challenging to diagnose during pregnancy because symptoms such as shortness of breath and swollen legs are common. As such, objective investigations are necessary for diagnosis. Clinical prediction rules developed for the non-pregnant population are not validated for use in pregnant people and should not be used. Relevant bedside investigations include basic observations should be carried out on all patients with suspected VTE. Pulse oximetry during exertion can be useful in exacerbating the ventilation-perfusion mismatch and monitoring the resulting hypoxemia. ECG should be considered in suspected PE to help rule out differential diagnoses. Relevant laboratory investigations include full blood count, FBC, may show a raised white cell count due to acute inflammation or help to rule out differential diagnoses. D-dimer is not indicated in pregnancy as it will give a false positive result. If DVT is suspected, Patients will often be initiated on anticoagulation until imaging can be carried out. Compression duplex ultrasound is the primary diagnostic test. If the ultrasound is positive, then anticoagulant treatment should be continued. If the ultrasound is negative but clinical suspicion remains high, maintain the treatment and repeat the ultrasound on days 3 and 7. If the ultrasound is negative and clinical suspicion is low, stop treatment. If PE is suspected but DVT is also suspected, investigate for DVT with compression duplex ultrasound. If it is positive, no other investigations are necessary as the treatment for DVT and PE is the same. If PE is suspected but without signs and symptoms of a DVT, a ventilation perfusion VQ lung scan or a computerized tomography pulmonary angiogram (CTPA) should be performed. These investigations involve radiation, and so there are concerns over the increased risk of developing cancer, fetal for VQ, breast for CTPA. Explain to patients that these potential risks are extremely small. No large experimental studies have verified them. They have only ever been estimated. Patients should undergo a risk assessment early in pregnancy and a reassessment if their health changes significantly, and following delivery to determine whether prophylaxis is appropriate. Guidelines for risk assessment may vary between hospitals. VTE can be prevented with daily dosing of low molecular weight heparin, LMWH. Local guidelines in your hospital set the particular version of LMWH and the weight-based dosage. Warfarin can cross the placenta and affect the growing fetus, so it is not usually appropriate in pregnancy. Direct-acting oral anticoagulants, DOACs, are usually avoided due to the lack of reversal agents in case of bleeding. In the acute setting, if the half-life of LMWH is considered too long, infusions of unfractionated heparin are an option. VTE is rare, but the risk of death, plus the relative ease and safety of treatment, means that there is a low threshold for treatment once there is a clinical suspicion. Start LMWH treatment dose and organize definitive radiological investigations as soon as possible. VTE is often overlooked when pregnant people present outside of a traditional antenatal context, such as miscarriage or hyperemesis. It can also be neglected when pregnancy is detected incidentally. Consider VTE risk whenever managing a pregnant patient in the acute setting. Treatment usually involves a once-daily, weight-based dosing of LMWH. Follow local guidelines. In non-standard cases, a hematologist may advise a twice-daily regime. Due to the risk of dangerous hemorrhage, LMWH therapy should be stopped 24 hours before delivery. Practically, the patient should be advised that once they are in established labor, they should not self-administer any further medication. LMWH is usually not restarted until 4 hours after the use of spinal anesthetic or removal of the epidural catheter to reduce the risk of developing spinal hematomas. Any antenatal treatment should be continued until at least 6 weeks postnatally or 3 months in total, whichever is longer. As the baby is delivered, the risk to the fetus is eliminated, and the patient can decide to switch to oral medications such as warfarin, even if they are breastfeeding. There is less safety data regarding breastfeeding and direct oral anticoagulants, so seek expert advice and have careful discussions with the parents. Postnatal presentation of VTE is common. VTE diagnosed within 6 weeks of delivery is considered provoked by the pregnancy, and so would be managed with a 3-month course of anticoagulation. Complications include sudden cardiac arrest in the case of massive PE, acute limb ischemia, post-thrombotic syndrome, residual pain, swelling, and erythema. This can affect up to 30% of patients. Increased risk of recurrence, chronic thromboembolic pulmonary hypertension. Thank you for joining us in this educational journey on understanding venous thromboembolism in pregnancy and the puerperium. Stay informed and take proactive steps to safeguard your health.